Tricuspid atresia. Tricuspid atresia is a cyanotic congenital heart defect characterized by functionally univentricular heart with absent right atrioventricular connection. The tricuspid valve is usually totally absent and the floor on the right atrium is occupied either by muscular tissue or a primitive imperforate valve-like structure. The anatomic hallmark of tricuspid atresia is the lack of the direct connection between the RA and RV. The only outlet from the RA is generally large and non-restrictive atrial septal defect. The RA has no inlet portion and is connected to the dominant left ventricle by a ventricular septal defect with entirely muscular rims. The size of the trabecular and outlet portions of the rudimentary RV is determined by the size of the VSD and the nature of the ventriculoatrial connections. The coronary artery patterns and the systemic venous connections are usually normal, while the course of the AV conduction system depends on the location of the VSD, typically inferior posterior to the defect. There are three fundamental categories of tricuspid atresia that are stratified with the VA connection and further subdivided by the degree of the obstruction to the pulmonary blood flow. First is the tricuspid atresia with no transposition. It's pulmonary atresia, pulmonary hyperplasia with a small VSD, or no pulmonary hyperplasia with a large VSD. Second is the tricuspid atresia with detransposition, pulmonary atresia, pulmonary subpulmonary stenosis, and large pulmonary artery. Third is tricuspid atresia with levotransposition. It's rare. Pulmonary or subpulmonary stenosis and subaortic stenosis. VSD size and the degree of obstruction is often dictate the clinical presentation and management of the tricuspid atresia. In type 1 tricuspid atresia, most of these patients usually have some degree of obstruction that worsens the closure of the PDA. Progressive pulmonary stenosis or VSD becomes more restrictive. The result is increasingly cyanosis. On the contrary, the patient with the normal or increased pulmonary blood flow at birth will show early symptoms of congestive heart failure and may progress to the pulmonary vascular obstructive disease. Type 2 tricuspid atresia had the adequate systemic circulation is predicated on the presence of the non-restrictive VSD, and systemic blood flow may be ductal dependent, and if there is a severe subaortic stenosis from the restrictive VSD, patient usually present with the features of the pulmonary overcirculation. So one has to diagnose the chest X-ray may be oligemic, plethoric, hypoechoic shelf at the site of the tricuspid valve and the reduced RV dimension, ventricular atrial relationship, size and flow across the ASD and VSD, presence of the aortic arch obstruction and the presence of the left superior vena cava can also be determined. The cardiac catheterization may be required for univocal echocardiographic finding, catheterization of the pulmonary vascular resistance PVR, or the catheter-based intervention and the enlargement of the restrictive ASD placement of the ductal stent. The definitive surgical repair of tricuspid atresia involves converting the parallel pulmonary and systemic circuit into one that is in series by diverting entirely of the same venous return into the pulmonary circulation, that is called as the RV exclusion, and this is accomplished through a series of staged palliative procedures that can result in univentricular physiology. So in the stage 1 palliation is performed in the neonatal period. The stage 1 palliation ensures that appropriate pulmonary blood flow, adequate interatrial mixing, and unobstructed systemic flow. So in type 1 tricuspid atresia, the degree of the pulmonary blood flow dictates the palliative procedure to be performed. The atrial saturation between 70 to 85% are considered adequate following these procedures. Patients with adequate pulmonary blood flow may be ductal dependent and require PGE infusion to maintain the ductal patency. Pulmonary blood flow can also be stabilized by systemic to pulmonary arterial shunt, such as modified Blalock-Taussig shunt and right subclavian artery to right PA. And this is modulated by the diameter and the length of the shunt and the side of the shunt of the systemic artery and the size of the pulmonary arteries. Alternatively, a ductal stent can be placed on the catheterization laboratory. Excessive pulmonary blood flow requires a PA band. Type 2 tricuspid atresia, the systemic outflow in these patients may be impeded by a restrictive VSD and aortic coarctation or extensive arch hypoplasia. Thus, in addition to the creation of a modified BT shunt, stage 1 palliation may require the VSD enlargement, coarctation repair, and the anastomosis between the ascending aorta and the main PA or a Norwood operation. Stage 2 palliation usually performed in 3 to 6 months of age when the pulmonary vasculature is matured and pulmonary vascular resistance has normalized. Stage 2 palliation has important goals of reducing the volume load of the single ventricle by means of a superior cavo-pulmonary connection, and this can be achieved by two methods. Bidirectional Glenn shunt is created by performing end-to-side anastomosis between the SVC and right PA, and this can be performed by the beating heart and cardiopulmonary bypass with or without CBP using the SVC and RA shunt. And the patient with a persistent left SVC will require a bidirectional Glenn operation. Alternatively, the Hemi-Fontan procedure, while technically more demanding and prone to sinus node dysfunction, simplifies the eventual Fontan completion. Here, the right PA is anastomosed to the SVC, and gusset or cryopreserved PA homograft material is used for the anterior augmentation of the confluence of the pulmonary arteries. The same material is used to occlude the enlarged RA-SVC junction and to create the roof over the SVC and PA anastomosis. The common problems associated with the partial cavopulmonary shunts include the development of the pulmonary atriovenous fistulas, right to left shunting with the resultant hypoxia, and aortopulmonary collaterals. Right to left shunting leads to the volume overload and systemic ventricle. Any addition source of PFB or the BT shunt, PDA, or patent RVOT should be taken down to decrease the volume overload of systemic ventricle. Furthermore, the concomitant procedures to address the adverse hemodynamic consequences should always be accomplished at this stage to optimize the systemic ventricular function in preparation for the completion of Fontan procedure. The final stage of palliation or the completion of Fontan procedures performed 24 to 48 months by directing IVC into the PA and thereby diverting entirely the systemic venous return to the pulmonary circulation and total cavo-pulmonary connection. And to be eligible for a Fontan procedure, patient require adequate size PA, means the PA pressure less than 15, PVR less than 4 volt, a competent systemic AV valve, and the appropriate systemic ventricular function. Two common variations on the Fontans are the lateral tunnel Fontan. This technique involves creating the intra-arterial baffle from the IVC to the PA using the gusset or PTFE, and this is sewn inferiorly around the opening of the IVC to the RA and along the arterial wall just posterior to the edge of the ASD. Superior, the gusset is sewn into the edges of the opening of the RA into the SVC and PA. Lateral tunnel is completed by incorporating the anterior edge of the PTFE gusset in the closure of arteriotomy and can be fenestrated to promote decompression of the venous pathway and enhance ventricular filling. The extracardiac Fontan, alternatively an extracardiac PTFE conduit, and can be used as interposition graft between the divided IVC and the undersized PA confluence, and this is generally performed at a slightly later stage to optimize the size of the conduit and adjust for the somatic growth into the adulthood. Touted advantages of the technique include the avoidance of the atrial suture line, protection of the atrial wall from high venous pressures, and in some instances avoidance of the CBP. During period of increased pulmonary resistance, a fenestration may be created to help maintain the systemic blood flow by the side of anastomosis of the conduit and adjacent RA. Operative mortality for suitable Fontaine candidates in the current era is around 5%. The early problems include the low cardiac output requiring the Fontaine takedown of fenestration with a prolonged pleural effusion. Late problems include thromboembolism, systemic pulmonary and pathway thrombosis, and pulmonary venous malformations, and right to left shunting and hypoxia, lack of hepatic effluence into the pulmonary circulation, protein losing enteropathy, plastic bronchitis, and diminished exercise capacity. Patients who fail single ventricle palliation may be the candidates for cardiac transplantation. Thank you.